Welcome to the second webinar of our three-part series of research. Thank you for joining us. Today's presenters are myself, Donna Sarvello. I'm the VP of Educational Support for NCBTMB, and I've worked in the massage therapy profession for over 20 years in different areas. Joining me are two of the most prominent people from Massage Therapy Foundation. Hello, Robin and Doug. Thank you for joining us, and can you tell us a little bit about yourselves?
Hi, Donna, and hi, everyone. I'm Robin Miccio, and just to tell you a little bit about my background, I have a master's in health science research, and I currently do research and program management full-time at a children's hospital in Philadelphia. I've been practicing massage for about 10 years, and I'm just very passionate about helping advance the profession through research, and I'm just so grateful to be here with you guys.
And hi, Donna.
Hi, Doug.
Hi, I'm the president of the Massage Therapy Foundation, and I am a massage therapist now for more than 40 years and live and have a clinic in Champaign, Illinois. And so I've been a practicing massage therapist, again, for many years, and also an educator in the field. So thrilled to be a part of this webinar today, and looking forward to all the great things we'll explore.
Excellent. So I'm going to give you a brief introduction into NCBTMB. We are a nonprofit organization. Our mission is to define and advance the highest standards within the massage therapy and bodywork profession. We have several programs available to massage therapists and educators. The first one is our board certification in therapeutic massage and bodywork, which is the highest voluntary certification in the massage therapy profession. We now have specialty certificates in different areas. We have our approved providers for continuing education and our assigned school code. For more information about NCB and any of its programs, please visit www.ncbtmb.org. So, Doug, give us a brief introduction for the Massage Therapy Foundation.
So we are a nonprofit organization as well, and our mission is to advance the knowledge and practice of massage therapy by supporting scientific research, education, and community service. So since our inception, we've funded over $1 million in research in the field of massage therapy. And not only do we fund the research, we try to make it understandable. And we make it understandable both for the therapists in the massage therapy community, also for clients, and to our colleagues in healthcare as well. So that could be through many things like research, the projects that we do. We just had our International Massage Therapy Research Conference in Alexandria, Virginia in May, which was fabulous. We have educational programs teaching therapists about research. Our community service grants, we've given about $500,000 over the year to bring massage to underserved populations. So there are many resources. We try to meet people at where they're at, whether they are therapists, healthcare providers, or clients who would use the services. And all of these resources, you'll find all of them at our website at massagetherapyfoundation.org.
Hey, Doug, how long has this organization been in existence, and is there anything special coming up?
Well, you know, next year will be our 30th year. So with the board just met, and we're coming up with a whole a list of things that we want to celebrate in our 30th year. So long history. Actually, you know, from that moment, there was definitely work a few years previous to conceive of the organization, to bring it to fruition, but formally next year will be our 30th year. So there's a long track record here and a lot to be proud of.
Very exciting.
Doug, since you are the president of the Massage Therapy Foundation, an approved provider of continuing education, and a board-certified massage therapist, can you explain to us the NCBTMB Massage Therapy Foundation collaboration today?
You know, it's so perfect, and we at the foundation so deeply appreciate the role that NCBTMB both plays in the profession, but also we're both trying to just educate the therapist and we all want to be better at what we do so that we can serve the clients who grace our doorways in the best way possible. It's really at the heart of the mission of NCBTMB and also the foundation as well. So in this way, collaborating on this, and I really love the idea of this three-part webinar. The first one that we did a while ago on the why of research, and then this one kind of the what, and then the where will be the third one. I so appreciate the fact the opportunity to collaborate with you on this one. And I think therapists, we've got a lot of great feedback from the last one, and I think you're going to find that people who are listening today a lot of great information and insight into this one as well.
Well, I couldn't ask to work with two better people on this project. This is wonderful. So, how do we earn 1 CE today?
Yeah, so today we're going to dive into some really great information and, you know, very educational in nature, and you should earn credit for that. And the NCBTMB has approved today's webinar as earning 1 continuing education credit. So at the end of the webinar today, we'll give you a link that you can go to that link and then take a quiz so that not only did you show up, but you are understanding and have the ability to integrate the information, and then you will immediately get a certificate to that effect, which will count for 1 continuing education credit. I alluded to the fact that earlier we did another webinar on why research is important, and you can listen to that webinar and watch that webinar and also receive credit for that one as well.
Excellent, and they're both free. I just want to make that point. So before we begin, I have a question to stimulate the listeners' mental juices. Why is research important to you both, Robin and Doug, and how often do you use it?
Robin, if you don't, I'll jump in right away on that one.
Yeah, please.
For me, I still see 1,200, 1,300 people a year, and I've been doing that for more than 40 years, and yet every week I see something that I've really never seen before. So in response to that, I mean, I can draw on my experience, but if I've never seen it before, it's a little hard to have anything to draw on, right? I can talk to people in my immediate sphere, therapists I know, but research in that way is a way to go to shared knowledge. Does anybody else know anything about this? What does the literature tell me about that? And is there anything that I can use in all of that information to help guide how I can approach that client? For me, it's an invaluable resource in terms of guiding my clinical experience every day. And it's been like that for many years.
And research supports what we do professionally and clinically. I mean, I share articles with patients and other healthcare providers, but as a clinician, I may pull elements from articles, such as to get ideas about how to measure my clients' outcomes, or even ideas about what techniques to apply.
Absolutely. And I'm jumping in, but Robin, to that effect, a couple of months ago, I spoke at the University of Illinois Medical School, and I'm sure that they saw on the, in the ledger for the day, oh, they have a massage therapist speaking to them today. Their response to this was to go to the literature, look up the literature about massage therapy, and these days there's so much more than ever before. So by the time I actually got into that group of, these were 4th-year students, the conversation was not about whether massage is useful or not. The conversation is, when should it be applied? How can this be integrated? That's a very different conversation than whether it is, but how to. And honestly, the data, the literature made that case for me, and in a way that I could never make, because having one person stand up in front of them saying, this work is really wonderful, it's like, well, great, I'm sure. Of course you would say that. But the literature made that case for me, so we can have a different conversation, a much richer, a much better conversation.
Right. And then to be able to connect with those healthcare professionals, we want to be able to understand what we're reading and speak the same language. So that's why I think this webinar is really important for us in our profession.
Absolutely agree.
Perfect. All right, Robin, let's get started. What is research?
Sure. So we all have different experiences of reality. And research is just a systematic way of measuring our experiences to gain a better understanding of the collective reality, or what's really happening in the world. And so we may get intimidated by research, but if we really break it down, it's just a structured process of investigating our questions, our facts and theories to explore connections between things and discover new knowledge. So there are many ways in which you can collect information to examine relationships and explore what's happening in the world. And the way, or the method, in which you collect information is called research methods. So when we look at research broadly, some believe that there are two general classifications of research methods. So we have quantitative research, which really quantifies what's happening by measuring or using numbers. So for instance, if you wanted to measure range of motion before and after massage, you can numerically see if there was an improvement. And then we have qualitative research, and that looks more at the quality of experience to get a deeper understanding of phenomena through description. And this is less structured than quantitative, but it's also useful. So for example, your client may state, when the therapist pressed on that muscle, I felt a release and a rush of blood to my fingertips. You can't really measure this. You can't measure someone's full experience numerically. So you can take this qualitative data, and that presents substantial value in itself.
And I would say, Robin, in the clinic, both of those things are really true. I understand that it's a research classification, but it's true, it's so true in the clinic as well, that there are things that we can measure. For instance, we might treat somebody's shoulder forward flexion, and before and after, the measurements don't look all that different, but the client says, but it feels so much easier for me to move. It feels looser and lighter and freer, but the numbers don't really reflect that. But numbers are numbers, and what people care about is their own experience. Yes, right. we'd like the numbers to improve, but the quality of their experience is no less than that, and it really takes both. So it's true in research, it's true in the clinic as well.
Yeah, and Doug, then you would be a mixed methods researcher, because
oh my goodness, am I? Oh my gosh, I always wanted
you
to be
value
one of those.
both elements here. So mixed methods is really just the blend of the two.
Oh, I always wanted to get there. Oh.
You made it.
Oh, thanks.
All right, so others theorize that research approaches are more on a continuum rather than separated into those two classifications you saw in the last slide. So if we look at this chart from Portney and Watkins' book, you'll probably recognize some of these research designs. And a research design is just a very specific blueprint, if you will, outlining the details of your study. So you'll see on the right, you have randomized controlled trial. In there, we have systematic reviews. We have case studies. You may have seen these before. Each design here is placed along a continuum of descriptive, exploratory, and experimental type research methods. So when we look at experimental research on the right, that employs more of those quantitative methods we talked about in the last slide. These are considered to be more rigorous, and it examines cause and effects relationships in a very meticulous way. And the most rigorous is the randomized controlled trial. It's also known as an RCT, and this is considered the gold standard in research. And we don't have time to review each research design today, but we're going to dive into the RCT, which is a type of experimental design, because I want to make sure when we're doing our literature reviews and we read these RCTs, we're going to be able to really make meaning out of them and be able to use them. So here is another way of looking at that continuum of research. This is known as the research pyramid, or the hierarchy of evidence. So I'll explain each from the bottom to the top. So at the bottom, the blue, we have, as clinicians, we may collect anecdotal evidence, ideas, opinions, and that's very basic. This can lead to a more systematic way to record those experiences, such as in the next level, the green level, the case reports or case series. Then we move up the pyramid to observational studies. Those look more at the natural relationships between things without trying to manipulate or change anything. And then moving up higher to the orange level, the RCT is the more rigorous research design, as we discussed. This is where the researcher manipulates one thing to see how it impacts another thing, and we'll dive into this. And at the tippy top here, we have the systematic reviews, which really collect a variety of randomized controlled trials and combine those findings. And so this is the strongest level of evidence.
So, Robin, I was going to ask, do randomized controls really apply to real-world studies?
I love that question because a lot of people say, you know, RCTs are the gold standard, it's the gold standard, and RCTs get a lot of praise because they can accurately state that one thing can influence the other. But in order to get to that finding, the researcher has to control for all of these outside factors. And in the real world, we can't control all of these outside factors. And so there may be other designs that are considered more valuable to clinicians.
And if I might jump in one thing, Robin, I was lucky enough many years ago to actually look at the pyramids of Giza, and everyone who's there is always looking up at the point because that's the thing that you are drawn by. Nobody's looking at the bottom thing, right? And in this pyramid, everything sits on the bottom rung, right? It's no less important. Everything begins there. Without the bottom, there is no top. So I think it's important that clinical findings are really the place where all questions begin. So all formal inquiries begin with an informal question. When therapists are in the clinic and they see something that over and over, there's some pattern to this, that question of why would that be is a really important question. Sitting in my office, I'm looking at this plaque I have on the wall. It's a quote from Isaac Asimov that says, "The most exciting phrase to hear in science, one that heralds all new discoveries, is not eureka, but gee, that's funny." It's like all of those new discoveries come from some surprising question that we learn by just observing the world. And it's on that everything is built from. So
I love that.
For those of you in the clinic, your experience matters.
Yep.
So you're saying that this is the foundation.
Yeah, and you know us, we're into foundations. Absolutely.
Yeah.
Yep. And you know, like Doug said, each level builds upon the previous one. So all of these research designs have an important place in research.
Okay. So next question, what is experimental research?
Sure. So now we're going to dive into the RCT research design. So we're going to start broadly. The RCT is a type of experimental research method, which is a more scientific, strict approach to investigating your best guess or your hypothesis about the cause and effect relationship between two things. So experimental research uses a scientific method. It's systematic, meaning that there are prescribed processes for collecting and analyzing information. It's empirical, so that means it's based on observation and facts. It's controlled, so that means the researcher eliminates all other possible factors that can influence the relationship between A and B. So if we use a concrete example, let's say you've worked with a patient who tells you, hey, my headaches go away after you massage my hands. So you're like, this is interesting. You hypothesize or you guess that there's a relationship between hand massage and headaches. So how might you conduct an experiment to test your hypothesis? Well, I'm going to start to integrate some research terms into this. So you have two variables, and a variable is anything that can be measured, objects, time, feelings. Variables can be broken up generally into two types. We have independent and dependent variables. So when we look at hand massage, this is our independent variable. It's the first variable in the equation. It's the variable that the researcher controls to see what effect it has on the next variable. So the next variable in this case is our dependent variable, and that's going to be headaches. So the dependent variable depends on the independent variable. it's responding to the change in the independent variable. And the dependent variable is measured, and the values may change when the independent variable is present or absent. So for example, the headaches may reduce in frequency or intensity with the presence of hand massage. And this dependent variable is also known as the outcome variable.
Okay, so next, what is a randomized controlled trial?
Yep. So if we break down that experimental method a little bit more specifically in the RCT design. So when we look at the RCT, if you look at this image at the bottom, an RCT polls many people from the general population and invites them to participate in their study. And these participants are also called study subjects. So these subjects, once they're selected, they're randomly assigned to two groups. That's why they call them the randomized controlled trial. They're randomly assigning them to two separate groups, sometimes more than two groups, but in this case, we're just going to keep it simple. We're looking at two groups. We have the intervention group and the control group. So our intervention group, this is also known as the experimental group, and this group is going to receive massage, which, as we know, is the independent variable. The control group then would not receive massage, so that variable is now absent. So the researcher is manipulating the independent variable by removing it from this group. So in this case, our control group, they're doing nothing. They're just laying down and enjoying. And then the researcher will measure the outcome variable between the groups. So in this case, it's the frequency of headaches. So the researcher is going to analyze whether there's a difference in the average number of headaches between the intervention group and the control group.
You know, as Donna brought up, though, it's a little tough in this kind of structure because it's hard for the client not to know they're not getting a massage. So that's got to be a little bit of a challenge when you look at the RCT sort of structure of this.
Yeah, definitely. Doug, you make a great point about the placebo effect. So people may have heard of this. This basically is saying that, you know, the outcomes are going to be influenced by what the participants believe is happening to them. And so if the participants are in the massage group, they're going to know they're in the experimental group, and that may influence the outcome. And so researchers try to control for this by using something called blinding. And that basically means that the researcher and or the subject doesn't know which group they've been assigned to. And that would help eliminate bias. But as you said, Doug, you really can't do double blind. You can't have the subject blind to which group they're in because they're going to know they're receiving massage. So then we would just have a single blinded study in which the researcher wouldn't know which group the patient has been assigned to.
Right.
That's a great point.
Is it also possible, Robin, to have the study where you intervene with one group and the other group is the control group, and then kind of measure that effect, and then maybe with the control group that didn't receive anything is now receiving something later, so they get to participate in both groups in a way? That's
a great point. That's a whole different research design. But there are many ways that we can look at this. But as a researcher, you would look at your research hypothesis and decide what design works best for you.
Thank you. Thanks for answering that.
Okay, before we begin this next section, I want to make sure everyone understands that research leads us to the conclusion. The conclusion does not lead the research. So when we're looking, the hypothesis is not the conclusion, it's the question, it's what we're looking for.
Right.
So Robin, can you give us an overview of the research process?
Yes. So now we're going to break down the steps of how you get from your research question to the outcomes of your study. And you're right, Donna, you don't want to start by saying, you know, I am going to make sure that we find this out at the end. You want to start with your research hypothesis and kind of see where that takes you. That is like the true process of research. So if we're using our RCT example, first you start with a research question. So what are you curious about in your practice? Maybe you think there's a cause and effect relationship between pediatric intercostal massage and asthma. And before you invest the time and the energy into designing a study, you're going to want to read through the peer-reviewed published studies first to see if the question has already been answered. This is called a literature review. If it hasn't been answered, you'll want to develop your best guess as to what's happening between the independent and the dependent variables here. So now we're going to get a little bit technical, only because folks often ask about these terms. So remember when I said you'll want to develop your best guess as to what's happening between variables? This is also known as identifying your hypothesis. So let's say in our example, your hypothesis is this: asthma will significantly improve after receiving intercostal massage for pediatric patients. If you're hypothesizing that there's going to be a change in your dependent variable, so in the asthma, this is known as an alternative hypothesis, noted as H1. You might see this in research studies. With every alternative hypothesis comes a null hypothesis, also noted as H0. So the null states the opposite of your alternative hypothesis. It's basically stating there's going to be no significant difference in asthma after massage. There's going to be no relationship between massage and asthma. So when you see, we can reject the null, that basically means that your alternative hypothesis has been supported. That's almost like an exciting moment. To reject the null means that, okay, well, my hypothesis has been supported here. And then the third step after that is you're designing your study. So as we saw before, there are many designs available. There's actually an art to this, depending on what your hypothesis is. And as you start to consider the design, you're going to have to answer the following questions. How are you going to select your subjects? When are they going to receive the intervention? When are you going to assess them? How are you going to assess them? What will your inclusion and exclusion criteria be? This basically means, who are you going to include in or exclude from the study? Maybe you want to include kids with poorly controlled asthma. Maybe you want to exclude kids with other respiratory problems like COPD. So this is a way that researchers can make the study more controlled. So again, an image of the randomized controlled trial here. And in this example, you're comparing the difference in asthma between the intervention and the control group. I'm just going to veer a little bit off track here. Doug mentioned another research design earlier, and I kind of want to touch on the single subject design. And this is another experimental design that you might see when you're doing your literature review. Instead of having an intervention and a control group, in this design, you only have one group, and the subjects serve as their own control. So the researchers collect data about asthma at baseline, and then they apply the intervention, and then they collect data from the same group after massage. And those two data sets, the pre and post, are now compared to see if there's a difference. So this is an interesting design. There's strengths and weaknesses to every design. And again, depending on your research question and your hypothesis and any other factors, you may choose this approach.
So how many times would you work on the same group to feel you've collected enough data?
I love that question. I think that that's a question of frequency and dosage, which is something that we talk about a lot in massage. I mean, if you think about everyone's doing a 50, 60-minute massage, but how long, or what's the duration, or what's the frequency of massage that's going to give you a positive outcome? And I think that really depends on the researcher and the evidence.
And speaking to that evidence, there are so few studies about frequency and dosage to make any kind of real determinations. This is one of the things we so need more studies to look at this. If you think about practicing the cello, learning a new skill, exercising, taking a medication, frequency, how often you do it, and duration, they matter. I mean, they can totally determine the outcome, but we in our field have not looked at that, and it would take more than 1 or 2 studies to be able to do that. there's a lot of work to do to really answer that question. So, you know, if I was that researcher, given the lack of data, you know, you pick something that's reasonable, see if it did or not have an effect, but then that becomes actually, let's look at those things. Would the same intervention done more frequently or done at a different dosage, would that have made a difference? That's kind of important information, and that could really be clinically useful.
Yep, and to take that one step further, I'm just going to go back. Remember when I said that, you know, most of the time you have two groups, you have your intervention group and control group. If we consider like a frequency type research design, you may have a third group that would be, you know, intervention group 1, 60-minute massage. Then you have your next group, intervention group 2, 15-minute massage. And then you have your control group. So again, just it depends what question you're asking, but just, you know, being able to design the study around that question.
Got it.
Okay, step 4, then you're going to determine the methods. So this is basically you're asking, how are you going to collect the data? How are you going to measure your outcome variable? Maybe you want to measure asthma symptoms. So you can count the number of days the child is wheezing or coughing. Maybe you want to measure function, which is usually most important to the patient, and we'll talk about that later, but you can measure whether the patient can walk up the flight of stairs in his home without wheezing or stopping. I'm going to get a little bit technical here, but I want to point out some terms that folks ask about a lot. You can assess or measure your outcome variable however you like, but more rigorous studies use existing measures. And when I say measures, I mean measures being the noun form, otherwise known as assessments. So you can use, you know, more rigorous studies use existing measures that have been tested for reliability and validity. And you're going to see these terms used a lot in studies, but what do they actually mean? So reliability means that if the assessment was applied multiple times, the results would be the same. You have consistency. Validity means that the assessment is measuring what it's intended to measure. So this more speaks to the accuracy of the measure. So if we look at the famous target example here, the bullseye represents a valid and reliable measure. So all the way on the left, in your first example, you're applying a measure. Let's say you're using a scale to weigh your clients, but the scale isn't calibrated and it's measuring 5 pounds too much. So although you may be getting consistent results, the results aren't accurate. So the scale is reliable, but it's not valid. In our second example, you use an accurate measure like manual muscle testing, but that takes a trained professional to conduct the test. That test is not easy. So it's really difficult to perform. So you may get a valid result, but you're not getting that valid result every time. So you may be inconsistent. So you can see that with the darts on the second example. And then our third example is neither reliable nor valid. And our fourth example, you're using a measure that gives you accurate results every time. And so some researchers dedicate their entire careers to studying the validity and reliability of measures. And as a researcher, you know, if you decide that you want to use a valid and reliable tool, you can go into research databases and find measures that have been established for your desired outcome. Step 5. So now you have to determine how you want to analyze and display your data in a meaningful way. You can do something very simple. If it's just you in the clinic and you want to see, you know, if your techniques are improving range of motion, you could use a goniometer and take measurements before and after, and then just look at percent change. That's simple, that will inform your practice. But randomized controlled trial researchers are using sophisticated statistical tests. Actually, they're often employing statisticians to do this, but the reason why they're using these sophisticated tests is because they want to be able to show statistical significance using p-values. And again, a little bit advanced here, but I wanted to touch upon this because a lot of people ask about p-values. You're reading research, you see this a lot. P-values represent the level of significance of the findings. So if we back it up, we talk a little bit about statistics. Statistics tell us about probability. So let's say we see that there was a change in asthma symptoms after massage. Well, what's the probability that that change in asthma occurred due to the massage? So we do that statistically. Now, here's something interesting. We can never be 100% sure that the change in the dependent variable occurred because of the independent variable. There's always going to be errors, and statistics takes this into account. So researchers, before they even go into the analysis, they're going to set a percent value ahead of time, indicating that statistical significance level. And traditionally, they're setting that level at 95%, which I'll talk about. So this 95% is represented in p-value form by the third bullet here. P is less than 0.05. So that's saying if the p-value is less than 0.05 in our example, that would mean that there's less than a 5% chance that the change in asthma occurred by mistake. Thus, there's a 95% chance that the change in asthma occurred from massage.
Very cool. So really in this way, Robin, if we change the number to 0.01, that would mean there's a 99% chance that the outcome that, you know, the help that the person got was actually due to the massage. Is that correct?
Yep. And you'll see that some researchers will set that p-value. Sometimes you'll see p is less than 0.01. That means it's just a stronger finding. I mean, they're just saying that now there's a 99% chance that the change in asthma occurred from massage. So if the p-value ends up being higher in this case than 0.05, researchers cannot claim statistical significance. Thus, they accept the null. We talked about that a little earlier. So they're accepting the null, that there's no change. If the p-value is less than 0.05, researchers can say with confidence, they can claim statistical significance and reject the null, thus support their alternative hypothesis.
Well, it's a pretty high bar.
Yep.
So even though p-value is less than 0.05 or 0.01, researchers don't use the word proof. Why is that?
Yeah, that's a great point. So researchers never say prove. They can only use the word support in research because, as we were saying before, they can never be 100% sure. There's always going to be some error there, and they're accounting for that statistically. So always use the word support, never use prove in research. It's a great point. So we're still on step 5, analyzing the data. And a lot of people ask, what's the difference between statistically significant and clinically meaningful? And clinicians like ourselves find that statistical significance is not enough. So maybe there was a statistically significant change, but was it clinically meaningful? Was the change large enough to even be detected by patients? You know, statistical significance doesn't necessarily measure magnitude or direction. So as a clinician, you may ask, like, did this dependent variable change enough to make a difference in the life of my patient? And some research articles will report this. They may report clinically meaningful data by using something called the effect size. So you may see that as well.
You know, Robin, I love that as a clinician because, and I'm just imagining this client who comes in and they come in because they can't, you know, they don't have full neck rotation. And what they notice is when they try to back the car, you know, out of the garage, they can't turn their head far enough. They don't have a backup camera because their car is too old. Yeah. And they actually have to turn their head. They're not great using the mirror, and they want to turn their head and they just can't do it, and they don't feel safe. So they come to see, you know, a therapist like, you know, you or I, and then we treat them and we get a change in the range of motion and we jump up and down and think, wow, this is awesome. But it's still not enough for them to back their car safely out of the garage without taking out the garage door in their neighbor's car at the same time.
Right.
So it might be an improvement to them. It might be, yes, it was statistically significant, but it's still not the thing that affects their life. So again, it's perfect for the research. It's also perfect in our clinic as well.
Definitely. And then the last step here in the research process is just to communicate findings. So all research findings are valuable, even if the hypothesis was not supported. And researchers should share findings by publishing in peer-reviewed journals, presenting at conferences, making posters. It's really important to build on that collective knowledge.
So how would someone go about getting their research published?
Well, I can speak to that, Donna. You know, one of the things is if you have that clinical experience, you can write up that experience, as Robin was alluding to earlier, in a case report, or, you know, that's a simple way to do it, or in a poster. But if we look at a case report, you describe that experience. Here's what was interesting. Here's what the literature said. Here's what I did. Here's what I found. Here's what I think that means. Here are the limitations and what it might mean for other people in this process, and then submit it to, as Robin mentioned, a peer-reviewed journal. So other people are looking at this, kind of making sure that it's solid, and then publishing it in a journal that everyone has access to, because insights that you learn by yourself and not shared, you know, we want to share that with the larger community so we can all benefit from that information. And we'll show you in just a little bit, this profession has our own peer-reviewed journal in which you can publish those kinds of things.
Mm-hmm. And then, you know, if you're not a professional researcher, you're not going to conduct an RCT, but like Doug was saying, you can conduct a case report. And again, that's so valuable for the established researchers, because they read case reports and say, this is an interesting finding. I want to look at this on a larger scale. And so that's very important.
Perfect.
Great. Oh, and then I will also say too that MTF has amazing resources for students and practitioners online about case reports. So there are other webinars and tools as well.
And more is coming.
More to come. Okay, so that's pretty much it for the research process. I hope that really helps you understand what you're reading when you're looking at studies. In addition, I just wanted to give a few tools that you can use right now. So this slide we're looking at is the PICO method. And this method is really helpful for folks who want to get started looking through research articles. Sometimes people get confused about what to type in, and so this really helps you identify the elements and frame your question to help support your search strategy. And so it starts with identifying the patient or the problem. So just breaking it down, let's say you're a clinician and you're interested in looking at patients with plantar fasciitis. And then it says, you know, what intervention are you looking at? I want to see if trigger point therapy on the soleus makes an impact. Then you go to comparison or control. Well, where do you want to compare that to? How about no massage or usual treatment? And compare that to trigger point therapy. And then what are your outcomes of interest? What are you looking at? I want to see if, you know, trigger point therapy helps these patients walk without pain. And so that really helps you break down everything so you can come up with a question such as this. Will trigger point therapy on the soleus muscle help patients with plantar fasciitis walk without pain? It really helps, you know, identify some of those key words that you're going to search in when you go to your journal databases.
And again, Robin, just coming up with that clear question, it's the clarity of the question that kind of determines everything that follows. Yeah. And this is a lovely thing. Again, in the clinic, it would be as simple as, if we're treating somebody, how will you really know if this person is better? And often it's tied to function. I want to walk this many steps, or I want to go up and down the stairs without pain. That is a very quantifiable thing that it's very clear. Yes, I can. No, I cannot. So how do we measure those things? It's great. It applies right to the clinic as well.
I love how you bring it back to the clinic and function, because function is really important to patients. We should change this last one to outcomes of patient interest. You know, because we always have to ask our clients, what do you want? What are you looking for after this? Right. And that kind of can help us, you know, inform our practice.
You know, because that's such a great point, Robin, because our outcomes of interest, like the things that we think, whatever it is, could be very different than theirs. But guess what? Whether the session in their mind was successful or not is going to be determined by whatever metric they were thinking. And if we don't know what those metrics are, good luck hitting that target, right?
Right. And they may not be coming back, you know?
Exactly.
So.
And you think, gosh, I thought I did really good work, and you know, this thing improved and that thing improved, but the one thing they were looking for didn't happen, and they think, well, that didn't help. But you never knew what that one thing was. So that's really great.
Collaboration is key. You know, always keeping that open communication.
Amen.
All right. So so you kind of develop your keywords. You have that question. You go to the computer. You start typing in. Doug will cover some of the databases that are available. But you know, you type into the database, and up pops a bunch of articles. When you click on an article, it opens. Most articles are going to look like this. They're going to have 4 sections: introduction, methods, results, and discussion. And so when we break it up, the introduction really involves that literature review we talked about. So the researcher is summarizing what's already out there, what's already been published around this topic. And then they kind of make a case for why this article adds to the existing body of literature. And then the methods section, and you know, now that we've went through the research process, you know what this is. It describes how the researcher designed the study. The results, this is where you're going to see the data analyzed. So you might find information about statistical significance here, effect size here, and the last section is the discussion section. That's interpreting the results. It's summarizing those statistical findings in more of like a meaningful, you know, way, and then it provides suggestions for future research. And so now that you kind of know what the process is, instead of reading each article word for word, you're going to know exactly where to go to get the information you need.
I have to say, Robin, one of my favorite things is to go to the discussion section and just see what was their takeaway lesson, what, you know, and oftentimes researchers will put in this suggestions for future research, which is really cool. Like, we learned this, but here are the unanswered questions that we're hoping somebody else would develop. Those are often really fun, just to see what the takeaway lesson for them was.
Yeah. And that's like true collaboration in research, like building on one another's findings.
Absolutely.
I will say too that sometimes you'll see abstracts, which are just, you know, mini representations of the entire paper. And so abstracts have all of these components, but are just pulling the key elements from those components. So instead of reading the full paper, you kind of get a glimpse first, and then you know what you're kind of getting into.
All right. Now that we've gone through the processes of research, how do I know what findings to trust?
Yeah, that's a tough one. So there are a few elements that I pulled here. So you're going to want to look for studies published within the last 10 years. So as we know, research builds upon itself. So whatever you're finding in the last 10 years should be kind of the most relevant. You also want to look at the location of the study. Kind of depending on what you're searching for, the findings may not apply to your location. You can also look at the methods and the study design now that we've kind of went through that. So you can look, what are the inclusion and exclusion criteria? Was there any bias involved? Were measures valid and reliable? This really helps you figure out, you know, whether you're taking these findings with a grain of salt and how much you're weighing these findings into your practice. And then another point is, you know, were the findings statistically and or clinically significant? And then lastly, is the author credible? You know, maybe there's a conflict of interest. Maybe the author trademarked a modality that he used in the study, and so that conflict may present a bias. Just always keeping this in mind.
And Robin, if I might add, you know, a couple other things, especially from years ago, if massage was shown not to be helpful for something, one thing is, so who did the work? You know, was it all relevant to the kind of ways that you and I might practice? Maybe, you know, it was a different discipline doing something that they called massage, but it is totally unlike and unrepresentative of things that you and I would do. Well, it's hard to draw conclusions of that because it it's not a fair comparison. And another thing is, you can find a study somewhere that says almost anything, but it's just one study. So that's why you need a body of evidence to look at this. So when people point to one thing as and put too much credence in just one study, like we talked about dosage and frequency earlier.
Yeah.
If one study showed that something was helpful, it's just one study. We need a multitude of studies so that we can get a general trend and to draw some conclusions. So I'm thinking about that the pyramid that you mentioned and the systematic reviews at the top. That's a case where you need multiple studies to even do that.
Yep. And that's a great point. Yeah, systematic reviews are taking findings from multiple randomized controlled trials. So that is the strongest level of evidence. And then also, which I didn't mention, is the number of subjects in the study. So obviously, the more subjects you have in a study, the more weight, the findings hold. Sure.
So I think all those things are things to look at when you're evaluating how much credence should I give this.
Yep, definitely. And then I just want to end here by stating that there's really no pure scientific method that can account for the influence of experience, intuition, creativity, and clinical judgment that we have as therapists. But we want to remember that science supports our clinical decision making. So we should consciously incorporate the best evidence out there when making informed decisions about clinical care. Yeah.
Amen. Amen. I feel so strongly about this that embracing the science deepens the art. It doesn't take away from it, because the deeper your understanding, the more choices you realize you actually have. And then it becomes the artistry of all of these possible choices. And if you don't know you have those choices, you can't choose, really. You're doing it by default and not by design. So I love the idea of the intersection of science and art being a sense of wonder and curiosity about the world. And that's just a rich, engaging experience, honestly, for the therapist and for the client.
Yeah. And that's evidence-informed practice. I mean, that blends your experience with the evidence to make quality clinical decisions and yield the best outcomes for your patients.
Yeah. And it's just a more engaging way to live your practice, right? Just always in discovery and always learning.
Love it.
And so one of the ways to share that knowledge is, as we mentioned before, in a peer-reviewed journal. So one of the really just big accomplishments over the last few years was the creation of the International Journal of Therapeutic Massage and Bodywork. And so many people played a pivotal role into making this happen. But it was such a leap forward for the profession, because if a physician is looking up massage and Parkinson's, you would think you would want that physician to be guided to something where the massage therapist played some role in helping to design the study, making it relevant to massage practice, that the people who did the work were actually massage therapists, and so that the whole thing is reflective of really the practice of massage therapy. So in the creation of this journal, a couple of things that are really important about it: it's free and open access. That means that open access means sometimes if you're ever looking at abstracts, you're doing a search thing and then you read it and you think, oh, that looks interesting, and then you go to actually look at the study and it says for $37.50 you can actually now read the full text, and you're thinking, I don't even know if I really want to read this. Why would I spend $37 to find out? So in the journal, we've paid all those fees for you. Everything in there is full text. There's nothing, behind the curtain. Everything is wide open. You can read the whole article. And this is made possible by sponsorship from the Massage Therapy Foundation, and also our friends at the Registered Massage Therapist Association of British Columbia, which have come in as a partner to make all this happen. So all those fees, all the stuff to make it happen, this is a gift to the profession. It's peer reviewed, meaning if you submit a case report, there are reviewers who are going to look at this, and they're blinded to who wrote it, but they're going to look for different criteria to make sure that this is, that meets the standards that we want to put it out there to the world. And putting it out there to the world also means that it is submitted to all these different databases, like PubMed, for instance. That's not inexpensive to put it out to all these services. And again, the journal has paid for all that, so that anywhere in the world, someone's typing in like massage therapy and again, Parkinson's, it's going to take them to our journal. And that's something to be really proud of, and a resource you should use, and it's free.
When I know I've signed up and I can get into this, but I think it's important for people to know that I believe that if they go to your website, then they just type in their information and then they get access to it. Is that correct?
Absolutely. Yep, that is correct.
Yeah.
And also, like if you also register, go to the Massage Therapy Foundation website, and then also go to IJTMB, and then when you register on that, when there are new articles published, you'll get a little push email just to let you know, hey, something new's coming out, you want to take a peek at it.
Perfect.
And not everybody wants to read a full research article, especially your clients, right? So one way to make that research article, the cliff notes, cut to the chase, here's what it was, is something called a visual abstract, or also known as infographics. So we have a bunch of these on our website at Massage Therapy Foundation. You just download them. You can print them. What do you call those? Rack cards, I think it's what it's called, Donna, where you print them 3 up, and then you can have them cut. And we have them little literature displays in our office of different abstracts that we think might be important for people, and you can share those. Like a client, like there's one, for instance, on Parkinson's, and a client is not going to read that whole research article, but they're going to look at, here was the study, here's what they looked at, here's what they did, and here's what they found, here's what that means. Cut to the chase in 1 minute, but what they understand is there are deep underpinnings to the work beyond just the therapist saying, I really think this might be of value to you. I think that's it's a wonderful thing for clients to see. This is a thoughtful and self-reflective profession who's thought deeply about these kinds of things.
And this type of information laid out in your front desk or in little areas in magazine racks, this is perfect to show that you are a responsible massage therapist, and it brings attention to different pathologies that people may have.
Absolutely.
I love this.
And you know what, somebody who, that's not their issue, but they see, wow, I didn't know that massage could be applied toward those sorts of things. And I think it just reflects really well on us as a profession. So the abstracts are one nice way to do that. We talked about case studies, but even at a level before a case study is a poster. And I love posters because they're so simple. If you've attended some major conference in the field, you've probably seen some of these up as these large posters. It's really kind of one person's abbreviated experience with whatever it is they're examining. So it's, again, here's what we found, here's why we thought it was interesting, here's what we did, and here's what happened. And all in a kind of one-page thing. I love posters. I find them really interesting. And again, if you're at that conference, good for you, but only the people at the conference get to see them. Now, anytime we're involved with this process, we take the PDFs of those posters, put them up on the website. You can scroll back through, find something that's interesting to you, download it and print it if you want, or just read the PDF and learn. And it's a great way that we can learn from each other. It's a learning community.
And will these be available at the future AMTA conference?
Yes,
there's
always a poster session at the AMTA conference. We had one at the International Massage Therapy Research Conference. Poster sessions are so interesting, and often the people who do that, Donna, they'll often be there. So it's fun to talk to people about, so what were you thinking, and why did you start this process, and what guided you along that way? It's a really fun conversation to have. We are also thinking at the foundation, we're going to actually talk to some of the people who created posters and have that video conferencing discussion about their poster, and do that little discussion that you might have at the conference. And we'll be posting all those to the website as well.
Perfect. So Doug, can you remind our listeners how to receive one free CE for this?
I can, and in fact, I think if you've hung in there through all this thing and you found it really interesting, I think you deserve it. And the way to do that, if you look at the next slide, so we have a link here that if you go to massagetherapyfoundation.org 2019 webinar and do a little quiz over the material, then if your grade is 70%, you can always take it over again, don't worry. If it's 70% or over, then you get a downloadable certificate right away, and you will have earned 1 continuing education credit through NCBTMB. And by the way, if you love today, but wait, there's more. If you didn't see the first one, go back. You'll see on that same webpage that you can go back to the first one about why research is important. You can watch that webinar, take the quiz over that one, and boom, you have 2 CEs that you can kind of add to your continuing education portfolio.
Perfect. So when is the next webinar?
What we're shooting for is the fall of 2019, and we haven't locked down that date yet. We should have an announcement for you fairly soon. And in this one, so the first one was the why. This one was kind of the what. The next one will be the where. Like we have alluded to some places to look for research. What we want to do in that one is dive a little more deeply, a little more vertically into all the different places you can go to look for really good information in the field. And I think you'll find that a rich and interesting discussion as well. So again, if you're signed up at our websites, we'll push you out an email to let you know when that next one will be. But it'll be the fall of 2019.
Perfect. So for all of you that are still listening, connect with us. If you have questions for NCB, you can go to our website, www.ncbtmb.org, or you can call us. And for the Massage Therapy Foundation, www.massagetherapyfoundation.org. I'd like to thank everyone for joining us, and we all look forward to our next webinar.
Thank you so much, everybody. Take care.
Thank you. Thank you. You know, it's a privilege, it's an honor to be able to do this. And for all of you who are watching this, it says volumes about who you are as a person, as a therapist, that you're a lifelong learner and committed to helping your clients. So thank you for the good work you do.